Thank you so much for having me. I'm really honored to be here, both in this particular conference because of the extraordinary range here, and then anybody from North America inevitably has sort of ANZICS envy if you're an adult intensivist, because in principle, the United States is supposed to produce large-scale, high-quality trials, and it seems mostly like what we do is implement ANZICS trials. Before I can go on, I need to say first, it turns out the US government turned itself back on about 2 hours ago, which is really good for my mortgage payments. I need to thank the US National Institutes of Health and the VA for their support of this work, and because I work at the VA, I need to comment that in case it's not obvious, this work does not necessarily represent the views of the US government, the Obama administration, or the Department of Veteran Affairs. I talk for me. And thank you again for having me. So I'm going to talk a little bit about adult sepsis. And what I want to do is try to help reframe how we think about adult sepsis. When we were all in medical school or in nursing school, we were taught a vision of sepsis that I think looked a lot like this, right? Sepsis was a hospital-acquired, procedure-associated ICU disease that was uniformly acutely devastating. For many of us who practiced at tertiary care centers, we were taught to think of sepsis as almost a pre-terminal event. It's part of the dying process. But in fact, research over the last decade has suggested a different, more complicated picture. That in fact, severe sepsis is a community-acquired disease frequently that's not a rare niche disease, but instead is incredibly common, maybe among the most common causes of hospitalization in the United States. That it's a spectrum of disease, not to the outpatient setting, mind you, but fully half of severe sepsis takes place outside of the intensive care units, even in the United States. And we know we like to admit patients to our intensive care units. Most importantly, most of the patients who develop severe sepsis will survive. And there are dramatic opportunities for the improvement in the quality of their care, both in their acute care, as the surviving sepsis guidelines have shown us, and also for their long term. But this is a very different way of thinking about the world. So in 2004, Gordon Bernard had finished publishing the Prowess trial, is perhaps the preeminent American trialist doing work on severe sepsis, and he's asked by an Indian newspaper, is there a residue in sepsis survivors who have had multi-organ failures or dysfunction? And he answers, stating I think what was a common view at the time, that most people return to normal or near normal lives, even if they've had severe organ failures. Persistent problems are rare. Most surviving patients come back to normal. And I wish Professor Bernard had been right. But in fact, some of the data I'll go over today suggests that's not true. That at least in older adults, perhaps nearly 2 in 3, 59% of sepsis survivors had worse disability or cognitive impairment after severe sepsis. And pertinently, that was not just concentrated among those who were the multi-organ dysfunctions, but was a diffuse lesion across people who survived sepsis. So what I'm challenged to do over the next 15 minutes or so is talk a little bit about what do we know about the long-term consequences of severe sepsis. In particular, I want to encourage you to think in the back of your heads about the term survivorship. What is it we can learn about survivors and their experience of having gone through this burning, searing illness and the long-term challenges they face? First, I'm going to present some data for you showing what I think is sort of the state of the art in the epidemiology, that arguing that the long-term lesions of sepsis are really focused in the brain, the muscle, and the long-term consequences. Next, I want to step back and look at some of the critiques of this work, which has argued that the long-term outcomes of sepsis were more about their pre-existing disease. And say, yes, it's true, sepsis does not actually solve pre-existing problems that you had before sepsis, but reframe that as an opportunity for intervention. And end by talking about what a next level of sepsis care for survivors might look like. In the absence of the ANZICS trial group developing some magic bullet that will actually solve everything, what can we go forward? So we've known for a long time that patients who have severe sepsis die. They die in the hospital acutely, but an awful lot of them die afterwards, exactly as text so elegantly showed to us. This is some data from a meta-analysis that was published in Critical Care Medicine that looks at of people who were survived to hospital discharge across 23 studies, what was their long-term mortality look like? And the actual details of the dots and the squares and the plus signs don't matter so much as it's up there, and it's up there higher than you'd expect for age-matched controls. And there's this sense that these patients were dying a lot. But of course, the criticism of that was, well, these patients were people who were sick to begin with. And so if you look back in the literature, there's a really beautiful case control study done by Quarton in the VA, published way back in 1997. And in the context of enrolling for another failed sepsis trial, they screened a huge number of patients and were able to carefully compare and match for a lot of prospectively collected data and ask the question of, are patients with severe sepsis at increased risk of death? Now, unsurprisingly, at the very top, in the first 30 days after they're diagnosed, sepsis is a bad disease, and they're at much increased risk of death. But what they did that's so fascinating and said, okay, let's step back. And what about those patients who survive at least 31 days? Are they still at increased risk for death? Yep. What about 90 days? Are they still at increased risk for death even after you've been winnowed out for all those? Yep. What about 2 years after severe sepsis? If you've survived 2 years after severe sepsis, are you still at increased risk for death? And the answer is yes. And this is a challenge to the way we think of sepsis. So many of us were taught to think of it as acutely life-threatening, and it certainly is, but we also need to think of it as fundamentally life-altering. Now, Christopher Hitchens, who was one of my favorite writers, had hideous esophageal cancer, perhaps not entirely surprisingly, and he had a horrible case of sepsis that he wrote about in Vanity Fair, and wrote with typical Hitchens-esque flair, "That which does not kill you makes you weaker." And let's go over some of the data suggesting that, at least in this case, Christopher was right. So the first is a fascinating piece that's just out in press. It doesn't have page release yet, from a group in Germany, where they took a group of ICU survivors and called them back, and they MRI'd their brain. And we can talk about why they chose to focus on the hippocampus, but on this axis here is their mean voxel count. It's basically a measure of the volume of their hippocampus. And the pertinent thing is, normal brains from their controls are up here, sepsis brains are down here. In the middle were non-sepsis ICU brains, a suggestion that there was a specific and focal lesion to the hippocampus among sepsis survivors. Now, obviously, they didn't have MRI scans of these folks beforehand, and so we can't sort out the selection versus the effects of sepsis in this trial. But it's fascinating. And likewise, there's a long-standing body of research looking at patients who have severe sepsis and comparing their muscle strength, and showing that very rapidly they have less muscle strength. You get focal muscle degradation when you're surviving with severe sepsis. But these are kind of the classic studies that our pure clinician colleagues laugh at scientists for saying, and saying, yes, so what? Tell me what this matters for somebody who's actual life experience. And in order to do that, I had the pleasure of working with a long-standing group called the Health and Retirement Study. And what the HRS has been doing is every 2 years, they've been surveying a group of nationally representative cohort from the United States of folks over the age of 50. And once you're in the cohort, they keep you until you die. 30,000 people have generously donated over 200,000 hours to this cohort. And when you're at a certain age, and many of us in this room may be beginning to feel this, every couple years you find yourself getting a little worse in your disability. And that's true even if nothing happens. But what we were able to do is say, you know, if you were a pediatrician, you'd look at this as a growth curve. And let's ask the question, among this cohort, who we know what they look like beforehand, who were prospectively surveyed, let's look at what happens when they get severe sepsis, and able to control for their baseline functioning and their baseline trajectory. How does severe sepsis represent a disjunction in that trajectory? For the epidemiologists in the room, we ended up doing this with latent growth curve models, which give you within-person fixed effects. I'd love to talk about the stats. I'm told that's probably not the point of this talk, so we can hold it for the Q&A session. But let's get to the results. So we followed about 1,500 patients. A lot of them died. But 623 lived to have at least one survey afterwards. And so we're going to look at the patients who survived severe sepsis, the 623, and compare them to themselves. This is patients serving as their own control before and after sepsis. What you see is in this last survey before sepsis, about a year beforehand, about 6% of them have moderate to severe cognitive impairment. I don't know if there are any geriatricians in the room. My geriatrics colleagues tell me I'm not allowed to say that's dementia because dementia is a clinical diagnosis, but boy, it looks a lot like dementia. In contrast, among those same people, a year after severe sepsis, that number is 16%. So you have a 10% absolute increase in moderate to severe cognitive impairment. This is a substantial lesion, not a subtle lesion on testing. For those of you who prefer regression, that's a tripling of your odds of moderate to severe cognitive impairment associated with the development of severe sepsis. So what about disability? To start with, we a priori decided to look at a group of divide people up by their pre-morbid functioning, thinking sepsis might matter differently for people who are doing well than people who are doing poorly beforehand. And so we start by looking at the people who had no difficulties on their activities of daily living or their instrumental activities of daily living beforehand. That's what's on the axis here. And good is down here, bad is up here. And this group had been doing well for the 5 years beforehand. And when they developed severe sepsis, this group of people who previously had no disability develops an average of 1.5 new limitations in their activities of daily living and instrumental activities of daily living. As you'll all remember from medical school, those are things like toileting oneself, showering, walking, feeding oneself. These are major lesions in an older population. Likewise, in the group who were doing okay but had some difficulty, they had an average of around 2 beforehand, and that shoots up to an average of 4 on average. Once you control in the regression, that's a new 1.5 new lesions, new disabilities in these patients who beforehand had been doing okay but not well. In contrast, there's a group of patients who were doing pretty awfully. By the time you have 7 limitations of activities of daily living and IADLs, you're in a lot of trouble. And these groups have been getting worse for the 5 years before they developed severe sepsis. For them, severe sepsis wasn't associated with a change in their trajectory. They had extraordinary mortality, but among survivors, severe sepsis didn't look worse. Where the big lesion of severe sepsis was in these folks down here, the folks who've been doing well beforehand who developed substantial new problems. Now, this work has similar findings to that have been brought up before. And it's raised the question of to what extent is severe sepsis actually causally associated with these worsening outcomes? The regression stuff suggests that it has been, but other critics of this work in sort of an intellectually playful way have asked, does that really explain the sort of, from a patient perspective, the burden of disease? And in 2002, the Pittsburgh group published a provocative paper in which they asked the question, does acute organ dysfunction predict patient-centered outcomes, really long-term outcomes? And they came down unequivocally. They say no, that it's overwhelmingly related to patient status prior to illness. And that's an important critique. And so before I go any farther, I want to stop and unpack that a little and ask, did they ask the right question? So let's go back to this graph we've been spending some time on. So you've got a group of people who are doing okay after sepsis and a group of people who are doing poorly after sepsis. And if you ask the question, what's the best predictor of which of those groups you're going to be in? Quite clearly, the pink is more like the red. The blue is more like the blue. And that's a fair and important point. What I suggest it says is that a lot of patients, when they develop severe sepsis, already have a substantial burden of disease on board. But nonetheless, even though the red is a better predictor of the red, among those patients in the blue, that's a real and significant increase. And I think it's a mistake to focus on the fact that there are some people who are doing poorly before and continue to do poorly afterwards, and to miss the fact that for lots of people, there's a new worsening that's substantial, even if it's not as bad as you can possibly get. So in this same line of critique has opened the question of how often do patients with severe sepsis really develop new problems? And what does their pre-morbid burden look like? Out at Seattle, Dmitry Davidoff, when he was at Hopkins at the time, did a classic meta-analysis on one of the topics that I think that really tugs at a lot of our heartstrings among us who are ICU docs. Looked at 1,213 patients in 14 cohorts and asked, how often are they depressed? And what he found was there was a median point prevalence of clinically significant depressive symptoms post-ICU that was 28%. But these were almost all those same clinical cohorts that only followed people afterwards. And so Dmitry wanted to ask the question, well, what does it look like in the HRS, where we can step back beforehand and see how big this jump is that's attributable to severe sepsis? And so we ran the numbers. This is a slightly different presentation, the same sort of graph. This is life after sepsis. Turns out among these people who had developed severe sepsis and were survivors, the point prevalence of significant depressive symptoms is 28%, almost exactly on the margin. And that is a huge number. That's 4 times the population prevalence of depression in the same population using the same instrument in a nationally representative study. But interestingly, they were really depressed beforehand. Severe sepsis didn't increase the degree of depression. And so one way to look at this is to say, depression and sepsis aren't a problem. This is not my fault. I don't have to clean this up. But another approach is to say, yeah, I'm not sure. As ICU docs, frankly, what we do is clean up other people's messes. We have complicated relationships with many of our colleagues in the outpatient settings who give people poisons, and then they get sick. And it's still our job to make them better. And what I would suggest to you that this says is even if these depressive symptoms are not new, 1 in 3 of our patients who are survivors of severe sepsis have major depression that may be substantially alleviated by treatments that they're almost assuredly not currently getting. Because one of the things we know is that the outpatient setting misses consistently some sets of conditions. And there's a long list of problems that are disproportionately prevalent among survivors of severe sepsis and other critical illness. And many of these problems, the challenges of weakness, the challenges of cognitive impairment, the challenges of depression, are ones we know that particularly in Australian, New Zealand, American, Canadian healthcare systems are poorly detected in most outpatient settings, which are overwhelmingly focused on the more conventional diseases. The ICU may represent a necessary opportunity for recognition and intervention of these problems, whether they're new or not. Regardless of whether we want to have the problem, regardless of whether the critical illness that was what we think of ourselves as doing caused the problem, there are patients and they have these problems and they're not being treated. This is an opportunity for us to bring our extraordinary resources to bear to make them better. So what can we do? Certainly if we could make sepsis better, that would be an unabashed great thing. Unfortunately, I don't have a randomized controlled trial to present to you right now that shows that it can eradicate the problems of severe sepsis. So what I want to talk to you about is a portfolio of things we can use to try to improve the experience of survivors right now. There's no single magic bullet, but I think there are a number of things that, particularly drawing on our experience in geriatrics and our experience in NICU follow-up clinics, we can pull on to ask, can we implement some of these now? Can we develop tests to refine them now in order to help us make the lives of these patients better? Because remember, they're probably 2/3 of our patients. The first component of this must be prevention. We must minimize the extent of critical illness. And here, the surviving sepsis bundles, the other work we're doing on excellent detection and resuscitation, likely plays a fundamental role in improving long-term outcomes. Frustratingly, I can't prove that to you. After decades of research, we don't have randomized clinical trials that on the whole have followed folks out long enough to be able to ask the question of, does excellence in this acute setting lead to excellence in their long-term outcome? That's a problem that many groups are trying to make better. Frankly, the trials group here is actively engaged in that conversation, and I commend them for that. I commend you for that. But we don't know the answer yet. Second, and I think there's some fascinating data, not least from Perth, suggesting that sedation reduction and early mobilization may play a fundamental role in preventing the problems developing in sepsis survivors and other critical illness survivors. And if we can prevent them, then we don't have to treat them later. But we're also going to need to protect these patients who are surviving the ICU, who are leaving vulnerable, and are at risk for developing new problems afterwards. From where I sit, particularly in the developed world, the discontinuities of care that we know happen on discharge, the number of people who go out not on their antihypertensive, not on their Synthroid, are astounding. It seems like a pretty easy win that if there are ways we can prevent these discontinuities of care, we make survivorship better. At the same time, we're going to need to remediate the problems that have developed. People are leaving weak. We know this. And so we need to strengthen those who are weakened by illness. Physiotherapy is obviously the linchpin of this, and the Australian group has been in the leaders of physiotherapy. Carol Hodgson's going to be presenting some fascinating work, unfortunately in a different room that I'm going to have to be talking at the same time, on the team study, suggesting some evidence about ways forward, but asking the question of what role does physiotherapy play in strengthening people to prevent them not merely strengthen them initially, but put them on a better long-term trajectory is really important. The second thing I'd like to suggest to you is we need to think more about supporting families as a core part of our survivorship. When we think about our families, we know they're exhausted. There's the work from France showing that they leave devastated, depressed, and anxious. Many of our ICU waiting rooms look more like Department of Motor Vehicle government waiting rooms than a place you'd ever want to sleep. And so we take families who we know are going to be the core buffer when patients are most vulnerable and when they leave the ICU, and we heedlessly deplete that physiologic reserve that our patients could have in the terms of their families while we're in their ICU. I think there's fascinating work to be done to explore the question to which strengthening families allows us to strengthen patients in the long term. Even if we make things better, we're not going to fix everything. We're not going to be able to undo the damages. What we need to do is provide assistance for unremediated problems. The easy part of this, the part we're currently attentive to, is thinking about the walkers, home oxygen, home health aides, and the ways in which we can give them the resources they need to compensate for their deficits. But I think the same thing we need to do is think about what are the ongoing, previously undiagnosed problems that may have helped them develop severe sepsis that we can fix with appropriate mental and physical health interventions to help strengthen them. And finally, we come back to cancer again, and the fundamental role of cancer survivorship, not merely in advocacy for cancer, but also in making cancer patients better. The way we treat breast cancer right now has been fundamentally shaped by breast cancer survivors reaching out to each other, teaching physicians new ways to think. We haven't mobilized that yet for the ICU, but if you wander around the web, there are fascinating survivor groups already trying to ask questions, already trying to innovate and find new ways to reach solutions for their survivors. And finding ways to capitalize on survivor peer support seems like a fundamental, untapped resource that may be available for us to help plug our patients in and help them make each other better. And so we've got some work to do. We have a situation where sepsis is very common. It has enduring cognitive and physical consequences for many, but not all survivors. We have patients who come in with a lot of pre-existing problems that sepsis isn't going to make better, but may provide a time when we can recognize and deal with those problems. And although we lack a magic bullet to prevent post-sepsis problems, what I've tried to suggest is there are feasible interventions that we can implement and refine now to help improve sepsis care for the many survivors and help make things better in the long term. I really appreciate your time, and I'm hugely grateful for the invitation here. Thanks very much.